All right. Well, hello. We're talking about the urinary system. So remember, whenever you're studying a body system, to make sure you go over the anatomy and the physiology of it so you remember where the landmarks. So right now, I'm sharing my screen. You should see the structures of the urinary system. We have two kidneys, a left kidney, a right kidney. Remember, the right kidney is a little bit lower than the left to make room for the liver. A patient or an individual could live with one functioning kidney. They would be a kidney donor if they were going to donate. If they had two good kidneys and they were going to donate, they could actually do that. If someone is a kidney recipient, just remember that they'll have to take immunosuppressive medications for the rest of their life so that their body does not reject that donor kidney. That's going to be important. So we have two kidneys. We have the tubes that are called the ureters. We have the bladder, the urinary bladder, and we have the urethra. So the urethra is the tube that gets that urine out of the bladder. At about 250 mLs, that's when your brain triggers, wow, I have to go to the bathroom, right? So those are some tidbits about the kidney or the urinary system. So let's talk a little bit more about what the kidneys do. So the kidneys themselves, they serve to regulate acid-base balance in the body. They serve to regulate fluid electrolyte balance. They serve to excrete your metabolic wastes, specifically creatinine, urea. The kidneys also help to regulate blood pressure through renin. And the kidneys, so that's the renin angiotensin 2, angiotensin 1 kind of system. So the kidneys also serve to secrete erythropoietin. And I feel like I should put that in the chat because that could be a question as well. Erythropoietin. So can anybody tell me what, I think I spelled that wrong, sorry. Can anybody tell me what erythropoietin's for?
Red blood cells.
Yes, absolutely. It helps the kidney makes that, secretes that hormone, and it goes to the bone marrow to help with the production of red blood cells. So, thinking like a nurse, I should know that if my patient has damaged kidneys, they're probably going to be anemic because they won't have erythropoietin. I'm going to probably have to give them epigen alpha, right? So, those are all things, getting in that, okay, if my patient has sick kidneys, what are some of the things I have to look out for, right? Okay. The kidneys also convert vitamin D to its active form for absorption of calcium. So if my kidney patient, is with me, I have to also check out their bone strength, right? That's another thing that I have to look out for. So the kidneys also serve to excrete water-soluble medications and medication metabolites. So that means I have to check out my kidney function if a patient is on, many different kinds of medications. So I want to check out the kidney function. So we know that the minimum output is what per hour?
30 mLs.
Okay, y'all are like a choir. Praise the Lord, right? Y'all are good nurses. Okay. So yes, 30 mLs per hour. Every patient should have that. If not, I'm going to get concerned. And I would say the only patient that may not have 30 mLs is my kidney patient that is on dialysis, right? Because we know that the filtering of the blood takes place 3 times a week during that dialysis process, okay? Now, things that we have to look out for or questions in our mind when we're thinking about the genitourinary system, the renal system, we have to think, does this patient have a history of genitourinary disorder? Do they have a history of hypertension? Because your hypertension, folks, can have issues with their kidneys, right? Because we just mentioned that the kidneys help to control the blood pressure. So here's it's not necessarily a fun fact, but this is a fact. That's why if an African American patient has high blood pressure, we really get worried about their kidneys. If you look at your dialysis patients, many of them are African Americans who started out with hypertension, right? So that's, teaching for us as nurses what to look out for. Also, diabetes as well, right? And welcome. Good morning, Brittany. We're just talking about, urinary system, remember, always go over the anatomy and the physiology. Remember, when we think about the assessment, we have to think, what is the function? So we've got 2 kidneys, 2 ureters, 1 bladder, 1 urethra. Fun fact, females have shorter urethras. That's why we're more prone to urinary tract infection. So the functions of the kidney: regulate acid-base balance, regulate fluid electrolyte, excrete metabolic waste, helps control the blood pressure, makes erythropoietin, which is essential for the making of red blood cells. It also converts vitamin D. We look for 30 mLs of urine per hour, except if the patient is a kidney dialysis patient, right? An end-stage renal patient. Okay, so when we're talking about contributing factors to our urinary health, we have to look if this patient has any genitourinary disorders, hypertension, diabetes, if they have a family history of renal disease. Maybe they have a family history of polycystic kidney disease. We also have to look out for incontinence, BPH. Okay, BPH is benign prostatic hypertrophy or hyperplasia. So that is not cancer. That just means that the prostate is becoming enlarged. The issue with the prostate becoming enlarged, and this picture I have doesn't have a prostate, but the prostate sits right about here on the male, right? So this is where the prostate would be. And let me just write prostate. And so if someone has an enlarged prostate, they're going to have these symptoms of urinary frequency, hesitancy, dribbling. They're going to have the feeling of incomplete bladder emptying. And so the procedure is called the TURP. Okay. If you're not familiar with that, please look it up. But in short, it is a procedure where they go in and they scrape out all of those extra cells, because hypertrophy or hyperplasia is extra cells, right? So they scrape it out. They remove those extra cells so that the urethra can have a full stream again. Okay, that's important. I'm going to pause for a second. Anybody have any questions?
Dang, I missed the third part.
Okay,
Sorry.
so TURP is transurethral resection of the prostate. That is if the patient has BPH, right? If their prostate is enlarged, and that is not prostate cancer. Okay, so
Is the teaching that they shouldn't take it with erectile dysfunction medication?
yeah, they should definitely not take any erectile dysfunction medication. Also, your hypertension patient that's on medications should not take that little blue pill either. Absolutely, that is correct. Okay. So BPH, so we're thinking about contributing factors to, issues with the genitourinary system. So we talked about, we mentioned hypertension, diabetes, if they have a family history of renal disease like polycystic kidney disease, if they have incontinence, and BPH is that benign prostatic hypertrophy or hyperplasia of the prostate, okay? Also, if the patient has cancer, that can contribute to some disorders or some alterations in the urinary system. Kidney stones is another one, right? So kidney stones. Remember, what is the teaching? Let me ask you, instead of saying remember, what's the teaching for a patient with kidney stones?
Increased fluids.
Yes,
Stool
it
softener. I think.
Okay, I don't know about the stool softener part, but definitely increasing fluids. Okay, we have to find out when the patient has these stones, we want them to strain their urine, right? If they strain their urine, that's where they catch the stones. We can determine what kinds of stone it is, because if it's if it's a calcium-based stone, then maybe this patient has too high levels of calcium, right? So we have to watch out for that, because there's about 5 different kinds of stones that the patient could have. But yes, increasing their fluid. So you usually tell regular, everyday adult patients to have about 2 liters of water, right? So this uh, patient that has kidney stones, they need to drink at least like 3 liters, right? 3,000 mLs of water per day to help flush out their kidneys, okay? All right, now that's your kidney stone patient. The other thing is I would brush up on my nephrotoxic medications because, and a lot of times those antibiotics, they're nephrotoxic and ototoxic. So be aware of those kinds of questions. That if the patient is on a certain antibiotic, what do we have to look out for? Well, we have to look out for their kidney health, right? And so one of the things when we're assessing our patient's urinary tract health, we're looking at their urine. Is it straw colored? Is it clear? Is it free from sediment? Is it odoriferous, right? Those are all things that we're looking at, okay? So the manifestations of someone that's having issues, possibly a urinary tract infection or issues with their renal system, they can have flank pain radiating to the upper thighs, to the testes or the labia for your females. We have to think about all of these keywords. I'll try to type them in. Um, so hematuria, you have to know what that means. Proteinuria, dysuria, frequency, urgency, burning, nocturia, incontinence, polyuria, oliguria, and anuria. So let's pause for a second because we really need to know what those terms mean. So anybody tell me what's hematuria?
Is that
Oh, blood
blood
in
in
the
the
urine.
urine?
It's blood in the urine.
Okay, excellent. Okay, what about proteinuria?
It's protein in
Protein.
the urine.
Okay, very good. Dysuria.
No,
Or
it's no
individual.
urine.
Yeah.
No,
It's
burning.
no,
Burning.
it's little.
It's burning.
Burning
Something
in the.
like this.
Yes, right. So it's difficulty with urination, right? So
I was
whenever
getting
you, yeah, so whenever you see dys, it's something that's abnormal and it's burning, painful, and urination. What about frequency?
A lot of urine, obsessive urine.
Yes, now you, okay. So yes, Jasmine. So frequency is going maybe 10 times in an hour, but may not have a large amount. It may be small amounts, right? And so they feel like they can't fully empty their bladder, okay? What is urgency?
You get like pressure down there, like you feel like you have to go. Yeah, the urge to urinate.
Yes, and you've got to go right now, like you can't hold it, okay? You
Mhm.
can't hold it, okay? You all know what burning is. What about nocturia?
That's when you use it during nighttime while you sleep.
Okay, nighttime, right? And so when I think nocturia, I think of possibly my hypertensive patient, right? So that could be something to think about. Okay, or my BPH patient. Okay, I know you all know what incontinence is. Incontinence. What's some of the nursing considerations for my patient that has incontinence, though?
Change frequently. Turn every 2 hours.
Mm-hmm.
Assisting to the bathroom. Making sure their lights on so they know.
Make sure
Okay.
they got on barrier cream.
Okay, yes, everything that everyone's saying, absolutely, right? So you can see those questions. The patient is taking Lasix or, sorry, furosemide, because you're not going to see Lasix on the NCLEX. So what are my considerations? Toilet the patient every 2 hours. Make sure the bedside commode is accessible. Make sure that the path to the bathroom is well lit and clear, especially at nighttime, because then they become a fall hazard. Barrier cream, those are all important things. So excellent. I'm also going to be concerned if they have polyuria about their fluid and electrolyte balance, specifically their potassium, right? So those are all things that you could expect to see. So just a reminder, review your lab values, okay? And I'm going to try to get to that, but that's just a reminder that we have to remember our lab values, okay? So the other things that I could expect to see, and you all are doing great, okay, and polyuria, who's associated with polyuria?
Cushion's.
Diabetes.
Renal problem.
Okay.
Diabetes insipidus. Yeah, that's true.
Yeah.
Yeah, diabetes insipidus. That's right. A patient with diabetes as well. Okay. Is the Addison's? She's dehydrated. Is she?
I was right the first. Cushion's.
Okay, let me see. That's worth looking because let's take a look at that. Okay, hold on. I've got annotate on. Let me turn this off. All right. Why can't this turn off for some reason? Okay, I'm having a technical issue. Why can this not come off of annotate? Here we go. No, it's not. Okay, hold on. Let me stop sharing for a second. Maybe that'll help. Okay, let me go back. Okay, there we go. She's under endocrine, I think. The Cushing's lady. No, sorry. All right, so you all mentioned the Addison's disease lady. So let's
Yeah, she's dehydrated. I remember now.
yeah, so she's the one that's dehydrated. And so these are all the things that go on, and this is an endocrine condition, right? This is a insufficiency, adrenocortical insufficiency. Remember, say that again.
She doesn't have enough steroids.
Right. And so those adrenal glands that sit on top of the kidneys are not functioning well. Or maybe this patient abruptly stopped taking their prednisone when they should have tapered off, right? So this is the patient that has that fluid retention, okay? So let's go back to the kidneys for a second. All right, so we were, okay. Oh, wait, I am not sharing.
We were
Okay, yeah.
talking about who had polyuria. We said diabetes insipidus is an example.
Yes, and they have copious amounts, right? And we're talking maybe 20 gallons of urine a day. So that's a lot. I shouldn't say gallons, I should say liters. Sorry. But yes, they have a really large amount. Okay. So also your diabetes patient, right? So you think polydipsia, polyphagia, polyuria, those are your patients with high blood sugar. Okay. Oliguria, what's that mean?
Without urine.
So that's
A
actually
little bit.
in,
A little bit. Is it
yes.
A?
Okay, so anuria is without, oliguria is little, right? Not up to our 30 ml mark. Okay, so they were singing in the choir like, no, that's A is without. Okay, so those are all terms that you should know, and you should know which kind of patient will have those conditions. Okay, so let's think about now that we kind of talked about the anatomy and the physiology. We talked about some factors. We talked about some of the signs and symptoms we could see. Let's talk about the diagnostic tests. So whenever you see these, you should also memorize the number, the numerical value. Specific gravity, we should know the color of the urine is clear or amber, straw colored. We know that the urine should be negative for glucose, for protein, negative for protein, negative for nitrates, negative for red blood cells and white blood cells. Remember, there's such a thing as macroscopic blood, and then there's microscopic blood. And for white blood cells, if the patient has white blood cells in the urine, what are you thinking? If my patient has white blood cells in their urine, say that again?
Is it infection?
Yes, it is infection. It
Infection?
is infection. Absolutely. Yes. Whenever we're getting a urinalysis sample, right? If we have to take a urine sample, we want to try to get the first void of the morning, if at all possible. Okay. Let's talk about a clean catch. So if we have to do a urinalysis on a patient that is a clean catch, and I know they probably don't do this when you go to submit your samples, right? You give 3 antiseptic wipes. You give a sterile cup, and so the patient should use those 3 wipes. If it's a female, we're going to use one wipe on the right labia, one wipe on the left, and then a clean. The third wipe is going to go down the middle. Okay, so they're going to sanitize their urinary area, right? Then they're going to start urinating. They're going to stop midstream, and then they're going to urinate into that sterile cup. Okay, for the males, they will use those 3 wipes, but they will start at the tip of the penis and go down to the base, right? And they will also start urinating and then stop midstream, because that's when we're doing a clean catch, we're trying to see what bacteria, if any, or what pathogens are inside of the patient's urine. This is for a culture, okay? All right. That's an important teaching thing. Let's talk about a creatinine clearance test. That, anybody know what that is?
Creatinine clearance kidney.
Yeah,
That's
something
right.
with the kidney, something renal.
Okay, yes, it is something renal.
That's
Okay, so let me say it like this. Does anybody, I'm gonna bring this picture in front of you, and maybe this will help. So when we do this kind of test, do these containers ring a bell? Okay, I think I'm probably not asking the question properly. A 24-hour urine collection. How do we do that? Or what is a
Is
24?
it a clean catch?
No, you pee from you test it for pee.
Oh, the straight calf.
No, it's not.
Tar, let me stop.
Is it for blood?
That's the one you have
For
to
blood
urinate. You have
glucose
to get that urine for 24 hours.
Yes,
And
who said that?
levels? No.
me, Brittany.
Yes, Brittany,
It's
welcome.
Melinda.
Yes, okay, so yes, 24-hour urine, okay? So 24-hour urine creatinine clearance test, okay? So this is an important one, okay? So this is like an example. If you've ever seen these brownish kind of containers, right? And they have it in the refrigerator. Does that ring a bell at all? But let's talk about it. So this is important because we're gathering and collecting the urine for 24 hours, right? But the first void of the morning will be discarded. And then we will collect all the other urine samples throughout the day, right? For a 24-hour period. The urine cannot be contaminated with toilet paper, cannot be contaminated with feces. Else we're going to have to start over. If we miss one, we have to start all over again. And it is kept refrigerated or on ice, okay? Any questions about this one? Okay, so this,
No, ma'am.
Is that the one you take out to rule out kidney disease?
yes, this is a very important one for kidney function to see if they're like a end stage kidney patient. Yes. Yes, this is an important one. Okay. All right. So yes. All right. Let me just write some things down because I feel I'm gonna send, who's the leader of the group? The group that's together. Jasmine, are you the leader of the group there?
No, we just logged in on my computer. Michaela, the leader, she the one around here reading every 3 minutes.
You can
Okay.
send it to me, Miss Ignacio.
Yes, okay, I'm gonna send it to you, to Linda, and to Brittany, because I don't know if all of you are together. Okay. But yeah, so McKay is the leader. Okay, excellent. All right, so BUN, right? BUN, you should be thinking, why didn't she say BUN? Like that's a big kidney thing. So you got to know that value, right? The BUN. Okay, let me go back. I'm going back to the kidneys just as a background. So the BUN, what's the normal BUN range?
7 to 21, Madison said.
Okay, if that's what your textbook says, then that's good. Okay, because I was thinking 10 to 20, but that's kind of close.
It say 10 to 20 in the textbook.
Okay, I would double check. I know that some places, like if you were at clinical or something, it might say 7 or something, but 10 to 20 is what I'm used to seeing. But just make sure that that's what your textbook is seeing. And the reason why I'm saying this, if you have a test question and you go by what's in your textbook, you can, challenge that question. So that's the reason why I'm mentioning that. Okay, all right. So let's talk about the kidneys, the KUB. What is a KUB?
Kidney, urinary, and bladder.
Yes, that is an x-ray, right? So these are all tests. Like if I think my patient has some kidney issues, these are all the tests that I could expect to see. And you have to know as the nurse what the tests are, how, quickly we get the test back, those kinds of things, because the patient could ask you questions and you're going to have to provide them information based on your scope of practice. So when we have that KUB, just like Jasmine told us, we're looking at the size, the shape, the position of the kidneys, the ureters, the bladder, and there's no preparation necessary, but we have to verify that the patient is not pregnant, as with any x-ray, right? Also, they can have a pylography, which is a contrast dye. So all the things that go with contrast dye, patent IV, assess for allergy, all of those nursing things we have to make sure are in place. Okay, so all of the other things that go with these procedures is informed consent, check the patient's creatinine level. The patient should be NPO for 8 hours prior to this pylography. Administer laxatives as prescribed, because somebody did say stool softeners, so that was good. Administer an enema or suppository on the morning of the test. Check for allergies, iodine and shellfish, right? Check for that. Let the patient know. Yes?
Sorry, I was just trying to give everybody the page number. In the red book for MedSurg, on page 217, and then on page 219 is the lab values for all the for the kidneys.
Okay, excellent. And they should commit those to memory for sure. You can't go wrong with that. And so tell us what's listed there, Makaya.
On page 219, bun, it says 10 to 20 milligrams. And then they have calcium 9 to 10.5. They have creatinine for males is 0.6 to 1.2. And then for female it's 0.5 to 1.1. They have uric acid for males is 4.0 to 8.5. Female 2.7 to 7.3. And then for your urinalysis, like for your color, glucose, ketones, pH, and protein, I'm gonna just say it's on page 217. It's a lot of.
It's a lot. Okay, so those are really important. Those are totally important, and you should know those lab values. And I was just trying to put the names in, but my typing is too slow to keep up with that. But yes, you should know the specific gravity, the protein, the glucose, the ketones. We shouldn't have any ketones in our urine. The pH should be 4.6 to about 8-ish, right? Or whatever your textbook says. White blood cells, serum creatinine, BUN, creatinine clearance test, right? All of that is going to be things that you need to know when it comes to your kidneys. Now, again, when the patient's having the x-ray or they having the pyelogram done, we have to make sure that we put all of those things in place, get them ready, informed consent, let them know that they're going to have a mild warm sensation. They may have a metallic taste in their mouth. Emergency equipment should be ready in case they have, an allergic reaction. After the procedure, encourage them to push fluids to get the dye out of their system. Okay. All right. The other procedure there could be is a renal angiography. And so this is when they're looking at the renal arterial blood supply. And so this is where contrast is injected through a catheter. And again, all the things that go with dyes and catheters, sign consent, right? Explain the procedure. We want to mark the peripheral pulses, right? And we always want to assess the pulses bilaterally. That's going to be important. Okay. Let's see. If your patient is having a renal angiography, they're going to be on bed rest for 6 to 8 hours. And after any kind of procedure like this, we could expect that we're going to continually take the vital signs at least every 15 minutes until they're stable. And whenever there's an invasive procedure, we have to look out for hematoma. We have to look out for edema, check the pulses. And with your kidney patient, always expect that you're going to have to check I's and O's, right? That goes without saying. Intake and output. Don't let them tell you that the ice chips don't count, because they do. Ice chips are actually 50%, right? So if the patient, if you're doing like a I&O kind of calculation, because that could be a question, the patient has 100 mLs of ice chips. Well, I know I'm going to add 50 ml to my calculation. Okay. There could be a cytoscopy. This is an invasive procedure in which a scope is passed to view the interior of the bladder, the urethra, or the position of the urethral orifices to remove calculi, which are stones, from the urethra, from the bladder, from the ureter, or if the patient may have lesions in their bladder, their urethra, or prostate. So this is something where you think about this patient may have bladder spasms. So we have to teach them deep breathing. We have to watch out for postural hypotension. Okay. We also have to keep this patient NPO if they're going to receive general anesthesia. Now, after the procedure, the cytoscopy, the patient may have pink tinged urine or tea-colored urine right after the procedure. However, bright red clots and bright red blood with clots should be reported. The same thing goes for your TERP patient. There should not be bright red blood or clots, because that is a sign of bleeding. Okay, that's an important one. If your patient is having a cytoscopy, we're going to make sure we look out for leg cramps, because they're going to be in the lithotomy position. Do y'all know the lithotomy position?
Can you review that? Because some of us do, some of us don't.
Okay, so think about when you are having your well woman exam.
Okay.
I'm gonna try to bring a picture up. Just give me a
Thank
second.
you.
You're welcome. All right, here we go. Because I know the visual aids are very helpful. Okay, so this is the lithotomy position. It's somewhat like the OBGYN exam position, right? Because our legs are elevated in that way. So think about this. If a patient, right? Because as nurses, we're always thinking, what's the complication that could happen as a result of this, right? Because we're looking out, we're like detectives, but we're looking ahead. And so, what is a potential complication? If this patient had a complication, how would I know it? What would the clinical cues show me? How would it manifest itself? Well, this patient, I'm concerned about blood clots, because they're in this position for a prolonged period of time. I'm concerned about potential cramping, right? So I'm also concerned about any discomfort that they may have, abdominal pain. So those are the things that we have to, kind of think about with every patient going through any kind of procedure with any condition. So we have to monitor for that. So that's why another reason why the pulses are going to be important for this patient, marking those peripheral pulses ahead of time. All right. So the other condition, for this, after they have the cytoscopy, you could offer them a warm sitz bath for comfort. Okay. And manage their pain. Okay. So let's talk about the renal biopsy. Any biopsy is an invasive procedure. I'm always concerned about infection and hemorrhage. Hemorrhage is going to kill the patient faster, right? So with a biopsy, they're going in with a large bore needle. They're aspirating fluid, cells, tissues to send it to pathology to determine, is it cancerous, or what kind of cells or what kind of fluid do we have. If a patient is having a biopsy of any kind, in this case, we're talking about renal, we're going to look at their bleeding, their clotting time. Are they taking a baby aspirin every day, right? Because we are concerned about potential hemorrhaging, right? So never forget, whenever a patient's having an invasive procedure, I've got to really monitor that bleeding time, the clotting time, the prothrombin time. So before the renal biopsy is done, you could expect that they're going to do an x-ray. They're going to administer IV fluids. The patient's going to be NPO for 6 to 8 hours. The patient is going to be with a pillow under the abdomen and shoulders on the bed. And that's a different position. Let me see if I could find a kidney biopsy picture. Let's see if this is a good one. Okay, this doesn't really show you. This is better than nothing. Okay, this might help our visual learners also. Okay, okay. So with this kidney biopsy, we're concerned about hemorrhage and we're concerned about patient positioning, and that should be one of the nursing things that always comes to your mind. For this procedure, how should I position my patient? For this condition, this medical diagnosis, how should I position my patient? That should always be something in your mind, because based on their condition, based on the procedure, is going to determine their positioning, right? And McKay already told us we change our patient's position every 2 hours. Okay, so this patient is going to be in the prone position. They're going to have a pillow under their abdomen, the shoulders on the bed, because we really want to get to their flanks. Okay, verify that they have informed consent, and the patient will be still and be instructed to be still. Now, post-procedure for this biopsy of the kidney, we want the patient in the supine position, and they need to be in bed for 24 hours. They're going to be in the supine position because they're going to be, it's like a pressure dressing because we're afraid of hemorrhage. Just like if a patient is having a liver biopsy, we're going to position them on the right side. All right. We are going to monitor this patient's vital signs that had this kidney biopsy 5 to 15 minutes for the first 4 hours because we're afraid of hemorrhage, right? So we're going to maintain pressure to the puncture site for 20 minutes. We're going to observe the client for pain, nausea, vomiting, blood pressure changes, encourage fluid intake. We're going to get the hematocrit and hemoglobin 8 hours after the procedure. Why is that? At 8 hours after kidney biopsy, we're going to get hematocrit and hemoglobin. Why?
To make sure it's functioning correct,
Still functioning back to function.
back to the function. No infection.
Mhm.
Yeah,
Okay,
filtration.
so we are concerned about infection, but we're going to monitor them to see if they have any bleeding, any hemorrhaging. Okay, okay, so we want that hematocrit and hemoglobin to be within normal limits. Okay, yes, 8 hours after the procedure. We're also going to monitor their urine output. We are going to make sure that the patient does not strain. They should avoid strenuous activity and heavy lifting for at least 2 weeks. Okay, so those are all important things with the kidney biopsy. Okay, let's talk about indwelling urinary catheters. Okay, your Foley catheters. Tell me, just go around the room, and what's your nursing considerations about this? Indwelling Foley catheters.
Is that the one you want to make sure is at kidney level, right?
Yes, so it's below the waist, right? So indwelling Foley catheter. Yeah.
You want to look at the appearance of the urine?
Say that again. I'm sorry, I didn't. You said the appearance of the urine?
Yes.
Yes, yes, that's correct. Yeah, don't be shy. Yes, y'all know this. Yes, absolutely. So the appearance of the urine, the color, the consistency, the amount, the characteristics of the urine. I'm really concerned about infection, right? When my patient has an indwelling Foley catheter, I am concerned about infection. So catheter care is going to be important. Maintain the bag below the level of the bladder. Put it on a part of the bed that does not move. Those are
Make
all
sure they drinking plenty of fluid.
Yes. Okay. Yes. So all of those things. Yes, you all know this, right? So yes, daily fluid intake. Again, this patient's going to be with I's and O's. Inspect the catheter tubing for kinks, right? And we only want this patient to have this indwelling urinary catheter, Foley catheter, right? For the time that they need it. Okay. Yep. Check for kinks. Okay. Yes, that's all very important, right? So make sure we clean the tubing as well. We're giving good peri care, but also cleaning the tubing as well, because we don't want those hospital acquired infections. Okay. Don't let them lay on it. That's right. That when we have the tubing, if it's pressing on the skin, that can also cause pressure ulcers or skin breakdown, right? So those are all important things when it comes to indwelling urinary catheterization. Okay. All right. And you all know the steps on how to insert that Foley catheter. It's a sterile technique, right? Because the urinary system is sterile. Review your steps because that could be a drag and drop kind of question. What are the steps in, inserting a Foley catheter or removing a Foley catheter from your patient? All right. So let's talk about cystitis. Cystitis is inflammation of the urinary bladder. Okay. So you all know with your kidney patients, as long as they're not on fluid restriction, we're going to let them push fluids, right? So no question will trick you if it's a UTI kind of question, or you're not going to choose restrict their fluids. That's not going to be the thing to do, especially if they're taking antibiotics. We want them to push fluids, right? To flush out their kidneys and their urinary system. Now with cystitis, this is an inflammation of the urinary bladder. So with all urinary things, we teach our patients to wipe from front to back because we don't want to spread E. coli. We don't want prolonged baths with excessive soap, right? We have to look out for males, benign prostatic hyperplasia, right? That they can end up with cystitis. Remember, cystitis is an inflammation of the urinary bladder. Okay, we look out for suprapubic tenderness, suprapubic tenderness. If they have pain in the bladder region or if they have flank pain, we look out for fever, malaise, chills, cloudy, foul-smelling urine. We look for increased protein in their urine because we're not supposed to have protein in our urine. We're looking for white blood cells in the urine. Okay, do they have CAS? Do they have bacteria in their urine? Okay, so that's what we're thinking about cystitis. The nursing intervention, we're going to do that clean catch that we talked about because now we have to grow these cultures to see, okay, what kind of stuff is in their urine, okay? We want to maintain an acidic urine pH. The normal pH of urine is going to be 4.6 to 8, right? And in my book, that's what it says. Push fluids greater than 3,000 mLs per day. Encourage the patient to drink cranberry juice, right? That's a good one, right? Apply heat to the perineum for comfort. We
Miss
would,
Ignacio,
yes.
is it not 7.35 to 7.45?
That is your body, but the urine is acidic.
So it's the higher.
Yes, so that's a good, so 7.35, 7.45 is the pH of the body, but the urine is acidic, just like the pH of your stomach is acidic, like it's like 1 to 4, right? So that's a really good question. Okay.
You say it one more time, the acidic lab value.
Yes, in my textbook it says 4.6 to 8 for urine. Okay. All right. Thank you. Let's see. So medications, I would expect antimicrobial medications, right? And so that's where you got to review your farm because some of these sulfonamides, there's a high allergy. Some of these antibiotics are nephrotoxic as well as ototoxic. And there are some urinary analgesics that will change the urine to different colors. So you've got to remember those as well. Okay, what is that? Phenazopyridine. That's the one that I'm talking about. Okay, hold on. Let me just put this in. So pyridine. Okay, that's one that you should know that will change the urine orange, okay? Okay, let's see. Cotton underwear, avoid bubble baths, increase fluid intake, void before and after sexual intercourse, and then cranberry juice daily. Okay, so the other conditions that we didn't have a chance to talk about is acute glomerulonephritis, nephrosis, okay, urolithiasis, which is kidney stones, and then acute renal failure and chronic kidney disease, and then dialysis. Those are the ones that we did not have a chance to talk about, as well as the urinary diversion. We talked about TERP a little bit already, and we talked about BPH. Okay, let me see. Okay, let me try to cover as much as I can. God bless you. Okay, let's see. Woo. So acute glomerulonephritis. Okay, well, I'm gonna turn to my pictorials because that could also be helpful.
Miss Ignacio, we don't want to keep you if I'm just saying if it's possible, if you can record it and then send it if you have to go. If not, that's fine. I just don't want to keep you.
Yes, no, it's okay. My family is still getting ready. I think they're having breakfast because we're getting ready to go to church, but they're almost ready. So I have a little bit of time. Okay, so acute glomerulonephritis, an acute renal disease involving the renal glomeruli of both kidneys. So I didn't really go into the depth of the anatomy and physiology. So think about what's the nephron is the functional unit of the kidney. And if I zoom in past that nephron, there's the glomeruli, right? So that's where all the action happens. So that's why your GFR, your glomerular filtration rate, is a super important level of value to know. That's what you get when you do that creatinine clearance test, right? So hopefully that's all coming together. So, again, acute is a sudden onset glomerulonephritis, an acute renal disease involving the renal glomeruli of both kidneys. So they're thinking that there's an antigen antibody reaction that damages the glomeruli of the kidney. So this may be a secondary response to an infection in other areas of the body. So we've seen something like this before with strep infections. Strep infection is, here's a scenario. Little Johnny, little Susie had a sick brother or sister. Now they end up with rheumatic fever. Little Johnny, little Susie had a sister that was sick. Now they end up with this possible strep infection. Or little Johnny or Susie had a strep infection and they didn't take the full course of antibiotics, or they did and they still have that infection. Now they can have rheumatoid fever or rheumatic fever, sorry, and then or they can have glomerulonephritis. So the common thread there is the streptococcus bacteria causing an infection in the patient. Now it's going to spread somewhere else in their body. Does that make sense, or any questions about that?
Yes, ma'am.
Okay, so again, that beta hemolytic streptococcus, okay? The manifestations, hematuria, cola or tea-colored urine with protein in the urine, edema, oliguria or anuria, hypertension with headache, okay, flank or abdominal pain, as well as anemia. And it's kind of neat because we talked about those things in the beginning. So now hopefully it's like, okay, I see these signs and symptoms, these clinical cues in my patient. So I kind of know now what's going on. I know the diagnostic tests. I know the nursing interventions. It all hopefully is making sense. This patient with acute glomerulonephritis should be on bed rest. We're going to restrict fluids increase calories and reduce protein and sodium in the diet. And I will tell you, if you have a kidney patient, we always want to watch out for their protein because their kidneys cannot process protein, right? So, and the sodium is to help with regulating their blood pressure. And we're going to monitor their daily weights. We will give penicillin to fight the streptococcal infection, corticosteroids if there is inflammation, and antihypertensive for the blood pressure. Okay. All right. I think I'm going to stop here. Okay. See.